Hello, everyone. Happy Thursday. It's almost the weekend. It is nearly 65 degrees here, so I feel alive. Spring is in the air. On today's whatever episode, whatever you want to call it, I am talking to my dear friend, Dr. Sheva Marcus. She's the founder of Maze Women's Health Center. It is the genius behind it. So, hi, Jenny. I have a lot of makeup on, guys, because I was just doing this TV appearance.
Hi there.
Hi, Batsheva. How are you?
I'm good. I feel like my Wi-Fi is doing weird things today, so I hope it doesn't give us trouble, but I can see you great. So hopefully you can see me okay also.
I can see you great too. I am so happy to talk to you today, and congratulations, everyone. Batsheva's book just came out. It's called Sex Points. I know, right? You've got it huge right behind you.
I know, I do.
Right behind you. I love it.
But you want to know what? It's in mirror writing because everything flips on Instagram. So this is literally in mirror writing. So it looks right to you. Crazy, right?
Yeah. I didn't even think about things like that. I know. I never think about these things until the moment. And then
my publisher provided it for me. I have one that's face on for Facebook, and I have one that's in mirror writing for Instagram. It's hysterical.
Well, my publisher didn't do that for me.
Oh,
You're so special.
Did you ask? Did you ask? You have to ask your publisher.
I did not ask. Is that what you have to do?
Yeah.
Oh, okay. Good to know.
We're getting a lot of hearts. I think the people like the mirror writing.
I'm sure they do. I'm sure they do. Okay, seriously, I have so many questions for you, by the way. People have a lot of problems with sex. Did you know?
Yeah. The time in my career. But the thing is, everybody thinks that they're abnormal and everybody thinks that they're broken. And I'm going to tell everybody who's listening, you are not abnormal. You are not broken. It is not nearly as complicated as you think, and you can have a good sex life. How's that?
See, everyone, this is all you need to know. All right,
okay, we're done.
Yeah, I know. Your work here is done. Everyone, you guys need to buy this book. I have read a copy of it, and I don't have my hard copy yet, Batsheva. I feel so bad. I really wanted to have it in time, but I didn't order it in time.
It has your thing on it has your blurb on the back. Nicole's really big on this book. I didn't bring one into this office. I was in my therapy office, whatever. I came dashing in. I'm like, I want to say hi to Nicole. Right, sorry.
It's all good. It's all good. I will be sharing about it when I get it in the mail, I think tomorrow. Anyways, yes, I have a lot of questions, and I actually I screenshotted them because I couldn't figure out how to look for them on my phone at the same time during live.
I have that problem all the time. I have to tell you.
Yes, I know. I don't think we can do these things. At least I certainly can't. I am not technologically savvy enough. So one of the first questions I got was, is it normal? And I don't know that this is your whole deal, but maybe it is. So is it normal after bacterial vaginosis to be put off sex for a month? I assume not wanting to have sex and for it to hurt.
So that is sort of not my thing, but I will say, first of all, can we talk about what sex is being defined as in that particular question? I think what she means to be asking, so it's she, is that she's been told not to have sex for a month, or she doesn't feel like it. And what she means is she doesn't have intercourse because her vagina is sore and hurts. And so you may not be able to have intercourse. But Nicole, you and I know that we need to stop defining as sex and intercourse as being synonymous. They're not the same thing, right? You can have great oral sex. You can have great manuals. You can use your hands, your mouth. You have another 100 body parts you could be using to have sex that do not involve your vagina. So if you're being told, and there will be times in your life you are told not to use your vagina. It could be post-birth, post-childbirth. It could be things are happening menopausally that you need to deal with. So that doesn't mean you can't have sex. You can still have amazing, amazing sex. So, and that's one of the points I make in this book, although points is the wrong word because whatever. But one of the things is we have to stop equating sex and intercourse. So you certainly do not have to give up sex for a month after any trauma or whatever to your vagina. You may want to give up intercourse for a few weeks if it's uncomfortable.
Mm-hmm. Yes, I agree. I know. And with bacterial vaginosis, yeah, like you said, it's really uncomfortable. So of course you're not interested. At least I wouldn't be personally.
Correct.
Yeah. Okay. So another question was, Oh yeah, that's about periods. So that's not what we're talking about. I don't know what happened there. Oh my God.
You are the period girl. You answer the period questions. I answer the sex questions.
Yes, exactly. I know. I'm just looking at what I screenshotted. Okay. So this is a good question. This is totally on you. What about stabbing pain deep in the pelvis, almost more in the belly due to deep penetration? Ouch.
So yes. Okay. So there's a couple of things. It could be endometriosis, in which case your doctor should probably pick that up. See, the issue is that there are certain conditions that most OBGYNs will pick up. Endometriosis is often one of them, although it's a little bit difficult to diagnose.
Yeah.
What we tend to treat more of are the vulvar and vaginal pains, which nobody seems to know that there's any problem. Like the doctors say, oh, I don't see anything, go see a therapist. That's the classic. Or, yeah, crazy, right? Or, and, you know, I don't know, my famous line at this point about, you know, if a therapist says to you, oh, regarding your pain, maybe it's your vagina telling you you're not ready to have sex. And I'm like, well, maybe it's your vagina telling you you need to find a new therapist. Okay. So, you know, that is just drives me nuts.
You just can't make this shit up, man.
You cannot make this shit up. You can't. So, seriously. So, but the other thing that happens with deep pain is if the penis that's going into the vagina is too long for your particular vaginal canal and it hits the cervix, and that's called, get this one, collision dyspronia. So you cannot make up these names. I always am joking around, Nicole, that they're coming up with more and more complicated names for women's pain syndromes because that way they won't complain about it, right? If they can't say vaginismus, vulvodynia, vestibulodynia, vulvar vestibulodynia, dyspronia, collision dyspronia, they're just not going to complain about it. Or now menopause is called genourinary symptoms of menopause. The genourinary symptoms, I have to get this without saying, symptoms of menopause, as opposed to just saying menopause. Anyway, I digress. I apologize. Collision dyspronia is if the penis is hitting on that cervix, and that could be really painful. And it's so easy to treat. It's going to sound so ridiculous, but they make these cushions that slide onto the penis and give you basically cushioning. You know what? Do you remember those Fisher-Price toys that were like the stacking rings that got like the children's bright color? So think of a stacking ring that would go around a penis so that it wouldn't get all the way into the vagina. But then we used to have these makeshift things, but now a company called Onut came out and they make these really beautiful, soft, rubbery, so they feel like your vagina. You slide them on the penis. I'm trying to think of a good way to describe it. You slide them on the penis so that it's like a barrier and the penis can't go in as far, right? The penis is, so he feels good, you feel good, all is well with the world. So if it's not endometriosis, check out the O-ring. The O-Nut.
Oh my, the O-Nut. Okay. What? You guys, did you know any of this? I did not know this. Okay. Yes.
I do want to say, Nicole, for anybody watching, this book has a huge deep dive into pain, but it also talks about low desire and problems with arousal and orgasm. So people watching who aren't necessarily pain people, just know that. Just want you to know that. Yes. I am the pain queen and the vaginismus queen, but yes, just throwing that out there.
You're so awesome. You know, somebody else asked this actually, can painful sex be an indication of endometriosis? I'm reading into it and hesitating if I should test for the condition. That's a whole other story. But yeah,
you should definitely talk to your doctor about ruling out endometriosis. It's a little tricky to rule out endometriosis because the only way to 100% diagnose endometriosis is to actually go in and do the surgery and see. Like the endometriosis is the tissue growing outside the uterus. So that's not a really good way to diagnose, to tell you the truth, but most OBGYNs can do a pretty good job letting you know if you have endometriosis. If that's something you should consider.
Really? I feel like they don't do a great job at all.
Okay, that's fair. They don't do a great job. They don't do a great job, and then they throw birth control pills at you. That's the other thing that they do. But you have to screen out endometriosis before you assume collision dyspronia, for example. You just need to screen out obvious severe endometriosis.
Oh, I completely agree with that. I know. And I feel like for whoever asked that question, if you're watching, with endometriosis, there obviously, or I mean, not obviously, but there tend to be a lot of other symptoms involved. There's typically pelvic pain either throughout the month or in the lead up to your period or at your period, sometimes really severe.
It's not usually limited to sex. I'll just say it's not usually limited to intercourse. It's not usually to intercourse or orgasm. Those are the two times when usually if that's the case, there's something else going on and it's not endometriosis.
For sure. Exactly. Okay. Other questions. We've got quite a few. And I want to get into your specific specialty, all the V words that you just said that I can't say fast. Okay. So this one person asked, I think I might have tight muscles as sex has always been painful and I'm able to hold my period until I'm on the toilet. And I don't think this is normal.
Fascinating. Okay. So yes, you have probably, again, I'm not diagnosing over Instagram, and everything we're saying is you need to talk to your doctor. But having said that, there's a condition called vaginismus, and vaginismus is a very, very common, and honestly, Nicole, this kind of breaks my heart because approximately 1 out of 10 women have vaginismus. It's like a crazy, it's an astonishing number. Yep. The number is somewhere between 8 and 17%. So I'm going to say 1 in 10 is pretty conservative. And vaginismus means your muscles are tight to the point where it's painful to insert something. So it could be not that bad and you can get a penis in, but it really hurts, which is kind of like what this woman who wrote to you is describing. Or it could be so severe that it feels like you're slamming a brick wall and that penis cannot get in there. A tampon cannot get in there. A finger cannot get in there. And the truth is that vaginismus is really an interesting thing because it lives, I always talk about it as it lives on this continuum between like fear and tight muscles. So there's some women who have like really, really tight muscles, but they're not so fearful. And there's some women whose muscles aren't actually that tight, but they're incredibly scared. And so like I do this X-axis, Y-axis thing, you know, like, so part of the treatment of vaginismus is stretching the muscles, and it's really not that complicated. We use these things called dilators, which are like little sticks. They're usually white. This is a black pen. This is not a dilator. And basically, think about if you were trying to learn how to do a split, Nicole, right? Every day you would go down a little further to try to get that muscle to relax. So what we do with patients in the easiest sense is introduce dilators into the vagina and slowly but surely introduce bigger and bigger ones until the muscles get more pliant and able to give, whatever. But the fear factor for some women is so overwhelming. And that has to do with your brain and your vagina learning to talk to each other and communicate. And so the second part of vaginismus treatment is getting your brain and your vagina to make friends. And you do that during the dilation process. No, seriously, you're laughing at me, but it's just,
no, I'm not. I think it's so cute. I love the language that you use. I'm not laughing at all.
Oh, no. You can laugh. Really I think if we laugh, it just makes everything easier. So, no, totally. So
I want our brain and our vagina to be friends. Truly.
We do. We want them to be friends. Exactly. The fact that this woman can clench so tight that she can hold in the blood from her period, it sounds like, I'm guessing she can also hold in her urine, would lead me to believe that her muscles are extremely, extremely tight, and they can be taught how to relax. And sometimes the fear is so overwhelming. I just want to say that, like, if you're listening to this, I have vaginismus, and I really, Maze Women's Sexual Health, which I'm the clinical director of, we are Vaginismus Central at this point. Like, women are coming in from all over. We're in New York, but women are coming in from all over for treatment. Women fly in from around the world for the Botox, which I'll talk about in a second, which is like a way to handle this. But every single woman sits down and starts to cry and says, like, I'm the worst case. I know you think you can cure this, Sheva, but I promise you, I'm the worst one you've ever seen. Everybody. And so and the thing, Nicole, is when people come in and they say, my desire's low, I'm having orgasm issues, we can help most women. We can make things a lot better. But when it comes to vaginismus or painful muscles, we got you. I promise you. Like, it's very rare that I would promise, like, it is so treatable. But what happens is women live with it, Nicole, and then the secondary problems get so much worse. They feel crappy about themselves. They feel terrible about their relationship. They don't get into relationships because they think something's wrong with them. They don't have kids. Like, I can't. We had a patient who was married 26 years. She had 2 children from artificial insemination because she'd never been able to have intercourse. For her 26th anniversary, she decided enough was enough. Her kids were teenagers, and she said she just wanted to do this for herself. 10 weeks later, she was fine. 10 weeks. Like, and think about that life. Think about all the things she went through. Like, that's what breaks my heart. Not that it's so easy to treat these. I mean, you probably see that with people's periods. You know, people get shoddy advice. Anyway, and then the secondary problems that happen are worse than the initial problem, right?
Yeah, absolutely. I know. I mean, we talked about this on the podcast. We talked about the fact that periods and painful periods and painful sex are basically synonymous, and the response is basically the same from the medical establishment, which is so unfortunate. It's kind of like, well, sorry, there's not a whole lot we can do.
Yeah, let's wait. Somebody I was talking to this week said somebody told her to wait until it got really bad. Come back when it's really bad. I swear. You said it. You cannot make this stuff up.
I know. And we just deserve so much better. This whole like, let's wait and see, or come back when it's worse, that's not responsible to me. It's so unfair to anyone who has a problem, because then it just perpetuates the problem of not going to the doctor, not getting help, not taking your concerns seriously.
I think sometimes the medical establishment just doesn't like to say, I don't know. They don't like to say, I don't know. And honestly, really and truly, that's why I wrote the book. I felt like if I can empower women to give them the information, a lot of the things in the book you can kind of do on your own at home. But some of them you really, really need professional medical help for. But if you can come in and you can say, listen, I don't actually think it's vulvodynia. I actually think it's vaginismus. Or this is the reason why I think it may be neurological as opposed to tight muscles. Then you're coming in as an educated consumer who can have a better conversation with your healthcare providers, who I think would like to help you if they could.
Yes.
I'm looking at some comment here. Not sure if you have questions. What are some low costs that you could recommend to patients who may be struggling with vaginismus? They want to know what that is. If you can, I'm going to tell you, buy the book. I know that sounds like so promoting, and I apologize, but I put a lot of time into explaining all these things in the book. So I can't do it in a minute and a half, but I will say this. Buying the first stop with vaginismus is dilators, and they're inexpensive and they're on the internet, and you can buy them, and I give instructions in the book on how to use them, and there are other books out there that do that as well. And I talk about getting your brain and your vagina to be talking to each other. So that is your step one. If you are not severe, the people that are flying in from around the country, from around the world, are usually, there's some women who can't, they're so scared and they're so panicky, they cannot, no matter what, no matter how lovely and kind and supportive the doctor is, they cannot get anything to their vagina. And so we developed this Botox treatment where we actually put women out for about 15 minutes. That's it. It's conscious sedation. They're actually not 100% out. We basically put Botox and lidocaine in the vagina. We open up that introital muscle, which is a muscle that's giving them all that trouble. You can't get anything past it. You press it and it gives once they're out. We inject Botox and they wake up with the large dilator inside of them, and they're very calm and relaxed. And for the first time, they're like, oh my God, I can actually get something in there. It's like, it is a life-changing moment. And now it doesn't jump over the treatment. Like after that, they still got to get their vagina and their brain and their vagina to be talking. They still have to dilate, but it takes them over the hump of the first step. Like it doesn't do all your work for you. It's not a magic bullet, but it's magic enough to get you jump started. And for some women, those are the ones who really are having a hard time and struggling. And those are the ones who will often fly in for the Botox. So I hope that answered your question. Most women can do this on their own. I know I'm going on and on. I got a text this morning. on Instagram from a woman who saw that the book came out. And she said, I need you to know that I came 10 years ago to have the vaginismus treatment. It was the only way I could have treated my vaginismus. You guys were incredible. You are the reason we have 2 children. I am now feeling like, she said, I would have been alone and miserable and sad. And now I feel like I am with somebody. I have 2 children. I am in a happy relationship. And I thank you from the bottom of my heart. And like, I just started crying when I read it, because I'm like, this vaginismus thing is so treatable, but it destroys people's lives because they're scared.
Yeah.
I'm sorry. I will now shut up.
No, that's an amazing testimonial. And I was actually going to talk a little bit more about that. I see one question here too. Somebody asked a question. Hold on. Let's see.
Somebody said totally buying it. I'm assuming they're talking about that dilator.
The book.
For it. Oh, the book.
You're
buying the book.
That's Danielle.
Danielle's
a practitioner. She's a practitioner, so I'm sure she's buying your book.
By the way, if there are any other practitioners watching, I am in the process of putting up a guide for therapists to use the book with their patients, a guide for PTs to use with their patients, and a guide for medical practitioners to use with their patients. So just saying, if there's any medical practitioners using it.
Yes, absolutely. I'm just looking to see what the questions were on here.
Sure.
Yeah, I just want to make sure I got everything because some of them are asking questions that are not applicable to this conversation. So can't really answer those on periods.
But Nicole will do another one on periods. Like everybody comes to you because they want their periods answered. And I don't talk about periods in this book. I'm so sorry. That's
no, you shouldn't. It's a whole book on its own. Are you kidding me? No, but okay, let's talk a little bit about vaginismus and the other conditions that you talked about earlier, because nobody really knows what those are. Like you said, they're so complicated, and how do you even get diagnosed? Where do you even begin? So can we talk about all of those conditions you talked about? Maybe start with vaginismus, like how does this start? And
so people
how does one get diagnosed?
Badly. People get diagnosed badly. You know this, right? That's the problem. So vaginismus, as opposed to, I'm going to break things into 3 categories right now. We're going to talk about vaginismus, vulvodynia, and then I'm going to give you subsets of vulvodynia, which is vulvodynia and genitourinary symptoms of menopause. So I finally got it out. Okay. What would you say most of the people watching, what the age of the people watching are? Just curious.
I mean, the age range, the sort of predominant age range on Instagram for me is 25 to 34, and then that 35 to 44.
Perfect. So I'm gonna put aside genitourinary, other than to show off the fact that I can actually damn say it. But other than that, I'm gonna put apart the menopause stuff because I think that's less relevant. So I'm gonna talk a little bit about vaginismus versus vulvodynia. Vulvodynia also is vulvar vestibulodynia. Okay. So vaginismus is tight muscles, right? It's tight muscles with this psychological component to it, which I talked about as well. How you get diagnosed, usually women start realizing they have it because they don't want to put tampons in, or they try to put tampons in, it hurts very badly, and they don't want to think about it anymore. And the idea of having intercourse is petrifying. They don't want to think about it. They just let it go and they just ignore it. That is classic. Then if they try to go to an OB for an exam and the OB can't do an exam, and a lot of women don't love OB exams, but usually people can relax enough to allow the OB to do an exam. If you can't do it, it's very, very likely that you have vaginismus, and it's some combination of fear and pain and tight muscles, and that's fine. You need to work on both, and then it's completely treatable. Sometimes women realize this when they get married, because what happens is often women with vaginismus don't like to think about the fact that they have vaginismus. Like, it makes them feel broken and ashamed, and so they're very avoidant, and they come up with reasons why they don't want to have intercourse. Like, I'm not going to do that till I'm in a committed relationship. I'm not going to do that till I'm married. I'm not going to date. I cannot tell you how many women I have who had all these reasons why they weren't dating. But the reality is they were scared of any kind of sexual contact because they knew it would eventually lead to intercourse. Although one of my favorite patients was amazing. She came in, and I love her. Okay, she came in, and she was somebody who ultimately did Botox, which was staggering to me because she was having great sex life, but she couldn't have intercourse. She couldn't get anything in there. And she kind of resented her boyfriend for pushing her to try to fix that. And I got that. But I feel like even if you don't want to have intercourse, you should be able to get into your vagina. You need to, for exams, for baby having, for any reasons. There shouldn't be a part of your body that's so scary that you can't approach it. Like, that shouldn't be the case. You should, even if you decide not to use it, even if you're in a lesbian relationship and you're not planning on having intercourse, you still want to put in a dildo or something into your vagina. So anyway, most of the women with vaginismus just don't want to think about it. They don't want to think about it. They put it off. They don't want to read about it. Right. Some of them then start realizing as they get older, wait, something is not right here and I need to address it. And maybe they go to the doctor, maybe they don't. And then the OB/GYN tries to do an exam, can't, and either is lovely and says, listen, I think you may have vaginismus. Let's talk about how to treat it. Or is dismissive, as in, you are just too tight. I cannot do a damn thing. Take a Xanax, or don't come back until you can get something into your vagina. Or I don't know what's going on with you, but
all those things you've heard before from a doctor saying to a client?
My God. Yes. Or women come in and then women who can have penetration, but it hurts a lot, will hear from doctors, don't we all have that problem? Love that. This is the one I hear more than anything. Just take a glass of wine and relax. Take a glass of wine and relax. If I heard that one more time, take a glass of wine. The doctors think that it has to do with relaxing, which it does, except that it has to do with this is not conscious relaxing. It's like if your back is in spasm, you cannot relax your back. Your vagina is in spasm. Like taking, right. Anyway. So, yeah. That's what happens usually. And then, as I said to you, Nicole, this one is heart-wrenching because it's so common and so treatable, but the secondary impact of it is so often so much worse. So that is essentially tight muscles, and that's vaginismus. So then when you hear the term vaginismus, you kind of know what that is. Okay. Vestibulodynia means pain in the, because dynia is like pain. So vestibule, pain in the vestibule, like in the area, getting in, right in front of the vaginal canal, you have pain in that area. Now, that can come from a number of different things. That can be secondary. If I say anything that's too complicated, just interrupt me. Or if I'm just going on.
No, I think everything, no, I feel like you're being very clear.
So pain in the vestibule can come from three different things. It can come from tight muscles because, and people look at me like I'm crazy. Usually people experience vestibulodynia as like a burning, sometimes itching, but like burning, like rubbing, like something it just hurts, like the skin hurts. That's the best way to describe it. The skin hurts. So when I say it's tight muscles, they're like, how does that make sense? And I'm like, if you take your fist and you squish your fist as tight as you can, Nicole, hold it tight. After a while, the area right here gets super hypersensitive and tender. So can you imagine doing that for like years? Like this area just becomes super, super oversensitive. So sometimes it's a result of tight muscles. Sometimes, and you probably know this better than anybody, it's the result of hormone imbalance because your vagina is incredibly hormonally mediated. Like your vagina needs hormones almost more than any other part of your body. So if you're on birth control pills and your body's no longer making any estrogen of its own or not making testosterone of its own, your vagina is going to be thrown off. Now, I really, 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 I am not saying anything bad about birth control pills. I leave that to you. I don't say bad. Some people do okay in my world on birth control pills, but some people, their vaginas are really, really sensitive to any hormonal changes. And so that's why also as you had a baby, you're pregnant or you had a baby, massive hormonal changes, and your vagina is really hormonally mediated. So it's going to feel it quicker than any other place.
And menopause.
And menopause, exactly. I just didn't say menopause because nobody's watching what's menopause. But yes, menopause.
There's a lady here who's 58, so yes.
Oh, yes. Okay.
Yeah,
that's
we got a few people.
Yes. So yeah, and that's so classic at menopause, right? So then you gotta either get rid of what's taking away the hormones, which could be the birth control pills, or you gotta put back the hormones. It's hard to do that when you're fighting the thing that's taking away the hormones, but okay. And then the third thing that could be causing the pain is neurological. You have too many nerve endings, but that is a small, tiny percentage of the pain. For the most part, what happens though, I'll tell you, Nicole, is that people come in with pain of some sort and the providers are really trying to help, but they give them piece of the problem. So they'll be like, especially with menopausal women or post-birth women, they'll be like, oh, I see your vagina is like, it's erythemic, it's thin, it's tissue papery. You need a little local estrogen in your vagina. But they forgot that the woman also tightened up her muscles because they don't see that. And so sometimes they suggest that they use dilators, but they don't deal with the hormonal piece, or they deal with the hormonal piece, but they don't deal with the dilators, or they don't do it in the right order. So basically, vulvodynia, vaginismus is straightforward, tight muscles. You get your brain in there, we can fix you. Vulvodynia, you kind of got to start separating. Is it because of the tight muscles? Is it because of the hormone imbalance, in which case we got to get you back to your hormonal, best self? Or is there a neurological underpinning, which is, that's the most complicated, but it's a small percentage. And that I'm not going to go into here because I feel like it's, there's surgery sometimes for that. There's medications you can use for that. That's the third thing. So those are, and then there's what you and I talked about before, which is also collision dyspronia. When the penis is your vagina is too short for the penis, super easy to fix mechanically with, a nice little cushion on that penis. So that is sort of, let me just say so one other kind of vulvodynia is vulvar. So vulvodynia just means pain in the vulvar area. Vestibulodynia means pain in the vulvar area, specifically around the vestibule entrance to the vagina. And vulvar vestibulodynia is another catch-all word that people use for that. It just sort of gives you the definitions there. I think I named them all.
I think you did, right? Yeah.
I probably bored people out of their mind, so I apologize, but
no.
Those are the pain syndromes.
No, it's really helpful. Someone said we need subtitles. Yeah, I am aware of that. I don't know how to do subtitles on a live. I don't know. If someone has thoughts on that, please share them.
Just remember, vaginismus,
yes.
All you have to really remember is vaginismus. and vulvodynia. Those are really the two that need to be remembered. Everything else is subsets of that. And then menopause symptoms.
Right. Okay. So of course, so basically those are all the conditions. And then getting a diagnosis obviously depends on a pelvic exam and having a doctor who is going to, you know, work with you.
It doesn't have to be a doctor. It could be a nurse practitioner. Honestly, then our associate medical director is probably one of the best in the country at this point on women's issues, a nurse practitioner. I'm a big fan of nurse practitioners. I think they take time and patience, and I love nurse. If anybody's watching who's a nurse practitioner, I love you. Okay.
I agree. I know. I love nurse practitioners as well. They're the best. I feel like they're the ones I see as well. So, okay. So that's the next step. And then treatment wise, I know you've laid out so much in your book. Do you have, just so everyone else knows, do you have sections on different conditions, or are you making sort of broader recommendations for everything?
No. So I think the book is, and somebody asked, how do you know if your hormone levels are out of whack? So let me get to that in a second. Although you have, you know, we have a little bit different way of testing it, because I think they're asking about their vagina specifically. So no, the way the book is set up, it starts with a quiz, you know, like it's a 32-point quiz. If you don't want to sit and do the math, there's a link, you can do it online and it gives you your full score. You take the quiz, and the quiz then breaks down your sex life at this point. It says, listen, I'm looking at 4 areas: low desire, problems with arousal, problems with orgasm, and pain. Here's your score, because in the end, I want you to have 100 points. If you're going to have 100 points, you're going to have a good sex life. It goes between, what?
A+.
Exactly. 100 points will give you, let's just call it an A. Let's call it an A, because some people could have 140. You know what I'm saying? Like 100 is good. You are good with 100. So, or even a B+ or an A-. That would be fine for most women, right? You don't need an A+ sex life all the time. You want to have one so that you can get to that A+ sometimes. But anyway, never had that analogy before. Anyway, so at the end,
it's 100 points is an A+. Usually.
Yes, exactly. So right, okay, you got it. So not if you were my children. They are maniacs. Okay, so anyway, so the reality is that this, at the end of that quiz, you should have a beautiful snapshot view of what's going on with your sex life. Like, here is where your general score is, and here's where you're missing points. These are the areas you're missing points in. And here's why you may be feeling it in this area and how it's affecting all the other areas. I call them quadrants. Like desire, arousal, I don't know if you can see it, pain, and orgasm. But how do each of these quadrants affect the other quadrants? And then the second half of the book says, it's like choose your own adventure, right? If you're missing points in this area, you should go to chapter 11 and 15 and 16. If you're missing points in this area, you should go to chapter 10, 12 and 13. If you're missing points, because I talk about things that you can do in the relationship, things that you can do with medication, vibrators. I talk about fantasy life, which I think is one of the most important underused things in women's sexual arsenal. That and vibrators, my personal favorites. I have a whole deep dive into hormones, both the hormones for your vagina and the hormones for your desire. So I go into very, very specific solutions in the book. Yeah, that was the whole idea. The problem was just the setup. The problems are just the setup to give me the platform to give the solutions, to get you points. I want to get you points.
Right. It's brilliant. It's so helpful. Do you want to answer that question about how to know if your hormones are out of balance?
So there's two different issues. I'm sure that you do. And I always say, whenever you're looking at hormones, you need to look at paper and what's happening in your body. Those are you need, and a practitioner that only does one of those is not doing you, is doing you a disservice. Yeah. So, we do blood testing. I think you do saliva, right? You do saliva testing, right?
No, I know. I do blood. I'll look at blood tests, but I like the Dutch hormone test. That's another one I use as well.
Okay, gotcha. Okay, yeah. So we do very traditional hormone testing on blood. When we're doing, so we want to know systemically what's happening. But if you're talking about your vagina, there's only one way to see what's happening with your hormones, and that is to look at your freaking vagina, right? Like, your vagina is the most honest part of your body. It will tell you immediately if it's screaming for hormones. It's so obvious, you can see it. We sometimes take photos to show women the beginning, what happens before they were on the birth control, or after, or before we gave them estrogen, or after we gave them local estrogen just in the vagina. So that's, anybody who gives you hormones for your vagina without looking at your vagina, you should find yourself another practitioner, because that is really what you need. And I know that there are tons and tons and tons of practitioners out there who are, especially for the menopausal women, who are very nervous about estrogen. I just want to actually recommend a book that's not my book, which I think is a really good book, called Estrogen Matters. And it's for older women. Have you read that, Nicole? Because I highly recommend it.
I know it though. Yeah, I haven't read it.
It's the best book out there on estrogen. It gives you the whole history and why there's so many myths out there about it from this freaking male-centered world again. So I think that answers the question. Anything you disagree with or wanna?
No. I love what you just said about your vagina being the most honest part of your body. I appreciate that, because I think with the testing, my thoughts on testing are that you don't need expensive, huge amounts of testing to know there's something wrong. I'm a big proponent of you knowing what's going on with your body by paying attention to the symptoms, learning to understand what your body's trying to tell you. And the way to do that is through body literacy, through understanding, the signs and symptoms. And we all have to do that. It's our responsibility to do that, because you can't be looking outside of yourself for solutions forever and ever. Obviously, if someone's coming to your clinic, that's a different story, but there's so much that we're able to do on our own. And you've done that in your book as well. So there's a lot of things that people can implement in their lives.
Right. And there are things, and there are like, if you feel like, yes, 100%, if you feel like something is not right in your vagina, you're right. There's something not right in your vagina. And if you don't want to go to a doctor to see about getting local estrogen or stopping your birth control pills or whatever it is, the book does outline alternatives, some of them over the counter, some of them not. Either way, you need to be educated so that you can articulate for whatever healthcare provider you're going to what you're experiencing and what you would like help with.
Absolutely. I completely agree with that. Right. And so if you don't have any idea what's going on with your body and you go to your doctor, you're likely not going to get a whole lot of help. I mean, that's been my experience and that of, I don't know, literally thousands of women I've talked to over the years. So that's really what it comes down to, is getting educated about your body and your vagina. So yeah. Oh, thanks. We're ordering books. Wonderful.
Oh, that's so nice. And somebody else said they liked Estrogen Matters. That is a great book. I know I'm supposed to be pushing my book, not other people's books, but that is a fabulous book.
I'm totally gonna get it. Somebody asked about maca root. I wasn't sure if you wanted to share a little bit about the different types of practices that you recommend in your book. Are you recommending food and supplements and things like that, or it's more physical practices?
So, well, I do talk a lot about having to feel healthy and whatever that means to you in order to feel sexual. Like, I do talk about that, but I don't do a deep dive like you do about what foods, it's amazing. It's amazing, the general health and well-being stuff you do in your book. I just didn't have space for that. And that's not really my area of expertise. And I do touch on some of the sort of alternative medicine options. I try to be as objective about them. Like, I'll give you one example. There's something called the O shot. Have you heard of the O shot?
I have, yes.
So I have very mixed feelings about the O shot, because there is no data to suggest that it actually works to help women's orgasms, right? I have a whole section on it.
You want to tell everyone what it is?
Oh, sure. So the O shot is PRP, or basically it takes your blood and we take blood, we do it. But we do it, and I'm going to give you a caveat. Like, it works sometimes, it doesn't work on others, but some people want to do it, and we'd rather they do it in a medical facility. So basically, we take blood from your arm, regular blood, and we spin it down so we get that platelet. It's platelet-rich plasma, PRP. So this was something that was developed for like sprained ankles. They've been using it more and more when there's damage or something happening in the body. If they take your blood, they spin it down, they take the platelets and they shoot it back into the damaged area or the hurt, injured area. It helps regenerate. And so a doctor came up with the idea of doing this with the clitoris, right? So, which sounds horrific. I know everybody's like, oh my, it's not painful at all. Many patients that can explain why it's not painful, but they can't. So, and I was like, there's no data. I'm not going to do anything in this practice where there's no data. But we were hearing anecdotally from women that it actually helped them. And we knew that it wouldn't be in any way harmful. So for those women who particularly want PRP in their clitoris, we do it. And we have had some women who say it makes a significant difference. More likely than that, we are going to say, let's take a look at some of the other medication you're on, your anti-anxiety medication, your birth control pills, where can we adjust things and help you adjust things down to get rid of certain things, or Wellbutrin is incredibly helpful for orgasmic issues, for example. It can be unbelievably helpful for that. And you're
Really?
Yeah.
I thought it was the opposite.
So what you're thinking of are the SSRIs, the serotonin reuptake inhibitors, Prozac, Effexor, Lexapro. It's fascinating. Those drugs are really a problem when it comes to arousal and orgasm. Wellbutrin, which is a dopamine agonist, it helps you raise the dopamine level. It's actually our first line for older women as they start losing their orgasm. Our first line after vibrators. Like vibrators are like, it doesn't mess with your hormones. My vibrators they are the most underused tool in a women's arsenal, but Wellbutrin can be unbelievably helpful. And there's 2 new FDA approved drugs out for women as well for low desire and arousal, which, you know, I'll be happy to go into at some point, but it's a whole other thing. Again, not home runs. I really believe, that's when I talk about the sex points. I really believe like the more options that we have out there, the more women are educated what's available, kind of the better. So we haven't found, I have personally not found that herbals at this point work for low desire and arousal, like maca root or horny goatweed, which I know is a great name, but we haven't found that it's super helpful. But some people, you know, DHEA, which is a precursor hormone, some people use. But again, if you're going to do that, I would highly recommend you do that under somebody's supervision, because it's a precursor hormone. It's not, this stuff, just because it's natural doesn't mean it's not medical. You know, like I don't know, people don't always get that, right?
And it's a hormone.
Somebody wrote, did not know about Wellbutrin. Yeah, there you go, Danielle. Yes.
You can't, and you also can't just slather yourself in hormones and expect there not to be an effect. Did I lose you?
Oh my God. Yeah. Totally not. I have this great story. Can you hear me?
Yeah, I can hear you fine. Yeah.
Because I have this great story. There was a reporter who I ultimately became very friendly with, who was writing an article for some women's magazine, and she called up. She was doing a first-person article about low desire, and so she was seeing this doctor, and she called me for some quotes. And I listened to her treatment, and the doctor was giving. I was like, they weren't testing her blood at all. It just felt really sloppy, and I was like, listen, forget the story. Just why don't you come see me? Like, just, you know. She came, and we ultimately became really good friends. We were well, not really laughing. We were horrified. Her doctor had given her testosterone, but he had told her to put it on her vulva. Your tissue in your vulva is really sensitive and sort of drinks in the hormones much more than other areas of your body. And her testosterone level was so high. I mean, so high. I mean, the amount she was using, we were like, we don't get horrified super easily. And the truth is, it wasn't really dangerous because it was very short term. It would have been if it had been long term. But I remember coming in and saying to her, you know, your hormone levels are like 200 times where we think they should be. And we're pretty aggressive with hormones. And she looks at me and she starts to laugh. And she said, you know, but Sheva, I was wondering why I was fantasizing about the grumpy old man who lives next door. I was like looking at him and thinking, well, he looks pretty good. And she said, it was really weird. And I'm like, yes, that's really weird. So you need to work with somebody who is responsible with the hormones and understands that small amounts can go very far and is listening to you, because it goes back to what Nicole was saying. Like, you're smart. You know what's going on with your body. You just need somebody to listen to you.
Yep, absolutely. Right. It's so true. You need someone to listen to you and take those concerns seriously, and then have a sustainable solution for you. This is so helpful. Or is there anything, I don't have any other questions. I know someone had asked about the maca root, and I know you answered that. I found it to be helpful. It just depends. Again, like all of these things have caveats with them.
Have you found maca root to be helpful? No, I always think helpful for sex, for what? For desire?
Yeah, exactly. Like just to get you kind of going again. But I feel like that's in combination with other things. I also find though that something like maca root and Vitex as well, they can mess with your periods. They can mess with your whole cycle. They can change ovulation. They can do all kinds of things. So it's really careful. You have to be really careful with the dosage and all of that, and just know that there are definitely side effects. But yeah, I feel like I don't have any other questions. I don't know if there's anything else you wanted to share before we wrap up, but this was so enlightening.
I always love talking to you. I feel like there's so much synergy between what we do and the people who follow you and stuff. So I really appreciate you making the time to make this live. I think this was so much fun. I'm, if any of your followers have other questions that you want to forward to me later, I'm always happy. They can DM you. They can follow me at Dr. Batsheva and DM me. And let's just fix women's sexual health or women's health altogether. Let's just get it happening.
I completely agree with you. So everyone, Sex Points is now available. Congratulations again on your book coming out.
Thank you.
And just, again, this is, I think, Batsheva, both you and I just say this over and over again, that for all of you who feel like there's something wrong, you feel like you're broken, you feel like there's nothing that you can do or there's no hope, I promise you there is. It's just sometimes we have to dig a little bit deeper. And I feel like in this book, you've really highlighted a plan for people. I feel like you were so clear from the quiz all the way through what people should do, or at least should try before going on to the next step. So thank you for that, for providing this incredible resource.
Well, thank you for allowing me to bring it to your followers, and let's just keep the conversation going.
Yes, absolutely, we will. All right, everyone.
Kiss.
Bye. Thank you all so much. We'll see you soon.